Hey everyone, today we're talking about a serious but fairly rare complication of a what we consider a roto-rooting procedure to open up your arteries. I know Dr. Lee Johnston is cringing as I say a roto-rooting procedure. I hate that too because it should not be considered a roto-rooting procedure, but that's how patients know when they get their leg arteries cleared out. And I ask them, what did you get done? They're like, oh, I don't know if I've had anything done. And I say, well, have you had a roto rooting procedure? And they say, oh, yeah, I have. And it's either that or I've had a stent procedure. Well, I don't like that too. That makes me cringe. So, anyway, there are complications that come with these things, right?
Of course.
And,
Yeah.
and that's why we say walk, walk, walk as much as you can and build a more natural, durable option, create those natural pathways with every step. Your body has the ability to do it. Um, but this one complication I want to tell you about today and talk to you about is called compartment syndrome. You know that very well. And it comes to mind because a couple weeks ago, late on a Friday night, the sister of a patient called me, and I could hear in the background the patient screaming in pain. She said she just had her arteries cleared out and she's in pain. They've given her all kinds of narcotics. They're now upping it to morphine. I don't know what to do. And I said, you need to get the doctor in there right now. And so the doctor comes in, puts his hands on her feet, says, I feel your pulses. Your feet are warm. You're fine. We'll up the morphine even more. And here I am yelling in the sister and the mother's ear, compartment syndrome, check for compartment syndrome. Lo and behold, what do you think it was? Compartment syndrome. And the doctor would have missed it, which is hard for me to believe that they wouldn't check for it because that kind of pain is not typical for a general angioplasty procedure, right?
That's correct. Now, let me ask you, is this patient somebody who had a pretty sudden blockage of the artery?
It seemed to have gotten acutely worse, but it was something that was there. This patient was a smoker. They knew that there were a bunch of clots that were building up on top of atherosclerosis in the aorta and the iliacs. They struggled with getting through on day one. So they put her on a TPA overnight, the catheter delivery of clot busting drugs for those who are watching. And they said they were going to go back in the next day and hopefully do a thrombectomy and suck the rest of the clot out. They went in the next day, sucked the rest of the clot out, said it was a success, but then lo and behold, acute pain. I mean,
Hmm.
severe pain, intolerable pain followed.
Yeah. Pain out of proportion to the exam is one of those hallmark features of compartment syndrome that you're nailing it right on the head.
Would you mind describing this? What causes compartment syndrome? And name a few scenarios by which you have actually seen it.
The issue with compartment syndrome is that the muscles in our leg are wrapped in this saran wrap layer called fascia. And it's pretty unforgiving in terms of stretch. It doesn't stretch very well. So if there is sudden swelling of the muscles in the leg, then it gets constrained by the fascia and the swelling really has nowhere to go. The muscles cannot bulge outwards at all. The saran wrap constrains them. So instead, they end up compressing the other softer structures inside this compartment, including the nerve, the veins, and ultimately the arteries. And so when there's sudden swelling, we worry about this. And the two most common scenarios in which I see the development of compartment syndrome and the need for fasciotomy, which is the decompression or the opening of that saran wrap layer to allow the muscles to swell so that they don't squash the nerves, the arteries, and the veins, would be trauma. So a severe injury to the leg, for example, like a motorcycle collision or a crush injury, perhaps that results in a lot of inflammation and swelling, and that can generate a compartment syndrome. A sudden blockage of a vein can cause a huge amount of swelling and a compartment syndrome. I've seen that a few times, but it's not very common. In the vascular surgery world, the most common reason would be somebody who has acute or subacute limb ischemia, meaning a pretty sudden blockage of flow, oxygenated blood into the leg. Then we fix it, and all of a sudden we restore blood flow to a leg that's been ischemic for hours or maybe even days. And suddenly there's what we call ischemia reperfusion injury. Now, it's a super nerdy term, but basically it means that there is a sudden inflammatory reaction to this leg that now suddenly has this rush of fresh oxygenated blood, and there's a huge amount of swelling. So if you come in with a cold, white, pulseless leg that's acutely ischemic, happened over minutes, hours, a day or two, and we suddenly restore blood flow, like with TPA, these clot busting medicines, a thrombectomy, we always worry about the development of compartment syndrome.
Yeah, I was shocked that they were not going to check for it. It blew my mind. It wasn't until I got the family to speak up that the doctor actually took the cover off of her leg to double check her leg. And I could hear him say, okay, well, this is probably going to be uncomfortable. And he pressed on her leg and did a grander exam. But it was this, oh my, you're right. We need to prepare the operating room. And at first, I've had a patient before, at a different hospital that they ended up it was so sudden and so severe, they literally had to perform it right there bedside. And what they do, right, is they slit, and I'm gonna let you describe it more, but what I know is that they just do a slit down the leg to release the pressure, and I'm overly simplifying it, I think. But when this one happened just 2 weeks ago, I was thinking because of the previous one that it needed to be done, like, right then. But then I looked it up and it says, you have up to 6 hours for most patients, before it can cause, permanent damage, supposedly. But of course, that's our favorite AI or ChatGPT saying that. But listening to this patient, there was nothing that was cutting that pain. And I just
Yeah.
said, please, dear God, please just get her down there. Just get her down there. Just open this. I mean, I was in tears. Her family was in tears. There was nothing we could do. And it was just wretched pain.
Yeah, and there are times where we will even do this prophylactically. If we know that a patient has been ischemic or without blood flow for 6 hours or more, and
Mm,
we're not sure if they are going to develop a compartment syndrome, or maybe we won't be able to do a good examination because they've had a brain injury or they're going to have their breathing tube remain in for any other reason, we might do this in the operating room at the time that we restore blood flow, just to take it off the table and treat it early, or at least prevent that from developing. There are 4 different compartments in the lower leg, and you are supposed to decompress all of them. You can do that through one, but more commonly 2 incisions, and they just look like big, long incisions on either side, the middle side and the outside of the leg. But we actually go in there and make sure that each of those accesses 2 compartments. And so all 4 compartments do need to be decompressed when that happens. Personally, I would not do that at the bedside, especially in an awake patient, but it is a time-sensitive issue.
yeah. At what point does it become limb threatening? I have had situations, well, one in particular where he did end up losing his leg.
Yep, it's happened. There can be incomplete fasciotomies, and sometimes it's because the ischemia was profound for a long period of time and the muscle died from that. Sometimes it's that the swelling kills the muscle. It can be a combination of both. But when we do the fasciotomies, we actually will test the muscles to see if they still contract. And that's our best suggestion that hopefully there's good function there and they will recover.
And I have had patients ask, well, is there something that the doctor did wrong? In my experience, the doctors have done everything right. And it's just one of those things that we just prepare patients for, especially if they've gone for a long time without blood flow. It could be a shock to your system, and you may end up with compartment syndrome. And you just have to be prepared for it just in case and know the signs and symptoms so you can alert your doctor right away.
Exactly.
Is there any tips for recovering from the fasciotomy? I mean, it's a pretty big procedure. You go in for a keyhole procedure and then you still end up with that cut down your leg. And there's still wound care and things like that that go along with it. What's your best advice that you give your patients?
Just try to be patient with the process, especially if there was a severe compartment syndrome, the muscles really bulge outwards. It can take a long time for that wound to close down. And sometimes it still requires a skin graft. We're not even able to close the incision primarily, and patients end up with a skin graft down the road. I have seen patients 10 years later, 15 years later, and they're doing well. So just be patient with the process. Recognize that even though the road to recovery is long, and I'm sure much longer than you had in mind, it is possible to make a full recovery, even if the wound stays open for a while, even if you need a skin graft. It is definitely possible to make an excellent recovery.
And final thought here, I think that the takeaway is there is a difference between reperfusion pain and reperfusion injury. And if the pain medication initially is not cutting it, I definitely alert your doctor, right?
Yes. Yeah, and compartment syndrome is really a clinical diagnosis. There are formal tests that can be done, mostly involving measuring the pressure in the compartments with a very large needle. So I tend not to measure compartment pressures. If I think that the diagnosis is possible, I will usually proceed with fasciotomies. Um, so it's really just about physical examination, getting a history from the patient, and some particular physical exam findings that will key you in that direction, like a lot of swelling or tension in the calf area, numbness between the first and second toe, numbness in the whole foot, weakness in the foot that was not present before. All those things will suggest that compartment syndrome might be at play.
Thank you so much, Dr. Lily Johnston. Really appreciate you answering some very important questions that we've been asked lately. If you want to subscribe to her channel, she has an amazing YouTube channel. Make sure you go to youtube.com/ the @ Lily Johnston MD. Wonderful content in there, more than 11,000 subscribers, so you won't be alone on her channel. You can also subscribe to ours for great content as well at The Way to My Heart. But please take a moment to like this video and subscribe to our channels and have a great day.